So I'll take you through a little bit my journey to the healthcare delivery system and a little bit about my background, the need for healthcare system transformation. I'll talk a little bit about the research in our lab, describe some of our foundational work in system architecture for healthcare delivery, a few applications, and then a little bit about digital transformation that I've been thinking about and have put together recently. So my work has been guided by a focus on improving the health of patients with chronic conditions. And I start us off there because a lot of people who are started off as biomedical engineers will say, oh, well, I'm a technologist. So I don't describe myself as a technologist. I describe myself as someone who is focused on improving the health of patients with chronic conditions. And that will help explain the root of and trajectory of my research. And I've really evolved that journey through expanding my system boundary. And I think that'll become clearer along the way. So I started my work at Berkeley and UCSF in bioengineering, where the mantra is technology saves lives. That's biomedical engineering mantra. And essentially what I was doing is looking at non-invasive biomarkers for MR imaging in neuro-oncology, so pretty focused on brain tumors. And essentially, if I describe what the work was about, it's measuring patient health state within the clinic. And so I work closely with my oncologists, radiologists, surgeons, pathologists, and they knew me as someone who was very eager to translate the work at the end. And I was very surprised by the limitations we were facing integrating the technology back into the continuum of care, despite having worked with the clinicians that I was interested in integrating things back with. And I'm sure it'll pop up a little bit more, but I'll describe in detail a little bit later. And then the other thing I recognized was that the first MR image that we took was still the most indicative of survival. So essentially everything else we were still doing by way of chemoradiation and surgery was not making a dent in significantly shifting someone's survival. And so there's this need to measure outside the clinic and not just within the clinic. The idea that if you show up and you're already being measured in the clinic, that it might be a little bit late. So that's where I took my first appointment as an assistant professor in engineering. And it was at Dartmouth Institute in Abu Dhabi, which was a new university started in cooperation with MIT. And so I was working closely with the MIT Media Lab collaborators and a few collaborators also at the Harvard Medical School. Essentially, rather than biological sensing, we moved into mobile sensing. And the idea is that you're capturing the data crumbs of someone's mobile information to now understand their biological, social, environmental, and other factors. And now we're trying to figure out how you can come up with non-invasive early warning markers for those. And so this is very much measuring health state outside the clinic. And we ran several studies. The fun study that, we captured information about obesity and BMI and how that affected eating patterns. We had the Ramadan study, which is fasting during the Ramadan time, which showed how eating was affecting sleep. And then we had our sleep fun study, which was showing how sleep is affected and affects social patterns. So the individual's health state are interconnected in various levels, and the technological and the actual health aspect of an individual is also interconnected. And so with all of that, I was interested in, again, integrating this into patient care. And this was at the time where wellness apps was the best you were going to get. It was essentially a closed door. You're either down the wellness app or you're in the healthcare space. So I said, I'm still focused on translation, and we need to improve health outcomes. And so that's where my research journey went into a theoretical gap that said, well, why is it that we have problems improving health outcomes with technology? And that we can't do it without integrating technology into the healthcare system, and then thinking of this system as an evolving, interconnected, socio-technical, complex system. And I'll describe that from a technical system science perspective. So the question that might pop up is, well, why is this a problem now? I mean, haven't we had successful translation of biomedical technology, think prosthetics? Or haven't we optimized microclinics or introduced data, or let's say digital health, but through, industrial engineering, operations, systems engineering, where we've improved things like patient wait times and things like cost. So what's different now? There's a few differences. There's an increase in the clinical knowledge and the speed of clinical knowledge. It used to be that you were a practicing physician, you studied, you practiced on that basis for the rest of your career. Now, by the time you enter your medical school and you exit medical school, some of that knowledge is already obsolete. There's also a very great increase in the technical and human resources in the system. And this is like the who of the system. There's also an increase of focus on personalized care. This one size does not fit all. And integrating the biological, behavioral, social, environmental aspects are also key. But most fundamentally is the change in patient needs from acute to chronic conditions. And so that takes into account the who, the how, what, when, and where, all of it. So let's talk about this a little bit more. In the mid-19th century, the biomedical model of care was that the body was a machine, essentially parts that are interconnected. And those parts meant that you can swap them out, and so we developed siloed departments, essentially in specialties by organ systems. And the green is to denote the siloed aspects of each type of care. You have dermatologists doing dermatological care in the dermatology clinic, etc. And so this grew out of a reductionist view of the body that led to the system structure of the healthcare delivery system, focused on acute care. But today, this same legacy system now needs to care for people with chronic conditions. And so what we do is we have these same silos, but we move people between the silos. So now we have issues of integration, communication, coordination, etc. But these lead to, well, before I talk about that, let's say, well, we've had technology and optimization, and we've used to put it into a system where you have a closed silo. And so you could see, and here I mean physically, see, just as we talk about Valentron and what you can actually see in front of you. Everything is happening within a place and a time that you can actually see. But now that it's being introduced to a system that's larger than the silos, you have to worry about upstream, downstream effects that you never really had to worry about. And so you end up with emergent system behaviors. And those are things like safety issues, poor patient outcomes, being lost in the system, poor experience. And emergent system behaviors can only be understood from a systemic view, from a systemic approach. And so a systems approach is needed for healthcare transformation. At its core, the structure, the form of the healthcare system was designed out of an organic system, but functionally how we use this system is now using the same legacy system, but you're trying to get out of it something different. So let's talk a little bit about, so then I ended up moving to Dartmouth and taking off my engineering hat and putting on a medical school hat, and expanded my boundary to the healthcare delivery system, where we focus on the modeling, our ability to describe complex healthcare systems, the data science aspect, so mathematical quantification of those models, and then taking that and helping in the redesign or design to improve actual care experiences for both patients and providers. And so this brought my background in biomedical and systems engineering, both the biomedical imaging and signal processing, but also the system architecture, modeling, and design from systems engineering, put together with data science and computer science, and clinical domains areas. And one of the things that is important to note is that we use both a synthesis approach, but also an analytic approach, and we use qualitative and quantitative. Some of our studies that we've run have been no data, the data capture is from my eyes, seeing what's happening. and others where it's very, very heavily focused on claims data. And this is an interdisciplinary approach to address several applications. And I will come back to these applications and describe them a little bit more. But let's walk through the system architecture a little bit more. And I know that I mentioned it a little bit, but let's go into a little bit more detail. So the foundation of the work sits on a system model that we architected for personalized healthcare delivery and the ability to manage individual health outcomes. And that rests on the foundational principles of what is a system. How do you describe a system? And so system has its form, its function, and its concept. The form is the pieces, the components. Its function is what it was, the reasons for why it performs the functions or of why it exists, essentially. And then the concept is the allocation of the who does what. And then we used a theory that we called heterofunctional graph theory, where we fuse this model-based systems engineering approach, which describes the systems portion that I just described, and network science to actually mathematically quantify these models. And so that allows us to really bridge the system space that tends to be a little bit more, let's say, not very data-driven in its approach, and combine those together. And I'll talk about how some of the value of that. Just a little bit further, you have the form, the function, and the concept, who or what it is that it's composed of, what it does, the who does what. But then you also have the individual health state evolution. It's trying to understand the dynamics of what's happening there. And then there's a coordinating function between that looks at how does the healthcare delivery system affect the health state of people. And how this is different than many other systems is that it's not deterministic, it's stochastic. And so you have 30% chance of killing someone or a 70% chance of saving their life. And so that aspect of the stochastic aspect is the part that throws people off, where you come and ask them, oh, well, what happens or what do you do? And you end up hearing a lot of things like, oh, it depends. Oh, so those types of things are why people say our things are complex, but then people feel like, oh, I can't describe it because it depends, but actually you can. And this model sits on the medical diagnostic model, where the foundation of it is that you examine the patient's complaint, measure, you're trying to understand, quantify, or classify a person's health state. You attempt to determine its cause, be it diagnose or decide on how to move someone within the system. And then you apply a treatment regimen to that cause. You're treating or transforming their health state. And then the last function is transportation, moving the person between these processes. And just to detail that a little bit more, we also have the description mathematically. Transformation is just a physical process that transforms the operand, here the operand being the patient, and not operand in the medical sense of an operation, but operand in the lingual sense of an operand to a verb, let's say. And so these are things like surgical processes, therapeutic procedures. There's decision processes. These are cyber physical processes that occur or should occur between the healthcare system resource and the patient, where you generate a decision on how to proceed next. This takes you into the planning processes or the scheduling processes. And then there's measurement processes, and this is a cyber physical process that converts some physical property of the patient into a cyber informatic property to ascertain their health state. So this is things like clinical evaluations, diagnostic tests, diagnostic procedures. And then finally, quite simply, transportation is just a physical process that moves the individuals, typically the patient, between healthcare resources. So that's the function. Then there's form, and form is the resources. And here, the resources are generally a combinatory or a combination between the human and the technical aspects. So transformative resources are resources that are able to transform the operand of the patient, the operand being the patient. Those are surgeons, cardiologists, and they don't typically do it with their technical resources like the operating theaters, delivery rooms, etc. There's also somewhat of a hierarchy to these. Generally, the transformative are the ones that if you are able to make decisions and transform, you're typically thought of as a transformative resource. And so someone like an oncologist, let's say decisions are capable of advising the operand on how to proceed. So an oncologist doesn't actually infuse the patient with chemotherapy, but they're the ones that are making the decisions as to when, how, where, dose, etc. And so they might also have their technical resource supports, things like decision support system or EMR decision tools. Then you have measurement, and this is a resource that's capable of measuring the operand, MRI technicians, sonographers, et cetera, and again, paired with its technical resource, a scanner or an ultrasound machine. And then you have your transportation, which is capable of transporting the operand. You have your, depends on what you call them. In the US, we call them runners or emergency medical technicians. And the technical resources here are either ambulances, gurneys, wheelchairs, et cetera. So this is a way to model all the resources and all the functions in the healthcare system. And as you can imagine, we can flexibly aggregate these resources up or down. And you can do so mathematically, and we do it, for mathematical description, then you're able to describe allocating the process to the resources, and we define this as our knowledge base. A little bit more technicalities, but this is our ability to model and take that model and describe it mathematically. So back to the applications portion. So we talked about applications being implementation, system design, improvement, equity, at least I believe it's also big here, but also in the US. And I described what's the real underlying problem here. So if we take something like implementation, I describe it as a siloed methodological approach. So scientifically, there's a lot of things that happen to determine, let's say, a model for healthcare, but implementation is the far end of it. And so the process is siloed. The actual scientific process is siloed. But there's also an issue of it being overly aggregated in the qualitative approach. So the details that are needed are also very high level. They're not described in detail. And so the underlying limitation of a siloed methodological approach is you have a suboptimal system boundary. Your scope is small. And the overly aggregated qualitative approach is a hierarchical problem. The level of detail is a problem. So from a systems perspective, you have scope and you have scale. And so a lot of these problems come up from a scope and scale issue, or a combination of the two. And so digital technology can support addressing these limitations. So let me get into a couple of examples. We specialize the architecture for mental health and opioid use. And here we describe the problem of design and implementation of behavioral health integration into primary care. And so from an engineering modeling perspective, it's very, very typical to find something like a model of a house, but the model of the house isn't what the builder is going to use. They need the building specifications. But it's the same model, it's just described at different levels of detail. So this is very typical in engineering. In medicine, you have the collaborative care model, and this is the one that's usually used for behavioral health integration, which describes the people and infrequent or frequent interactions. And then they updated it in 2017, put the patient in the middle, and added the registry. And then comes a core components and tasks list. But it doesn't describe who does what pieces, when they do it, under what circumstances, and how often. And so it gives rise to variations in implementation success. So what we did is that we did a retrospective model, and this is an activity diagram, so functionally describing what's actually happening in a clinic at our local hospital. And so we used qualitative methods of interviews and shadowing to develop this, but then we also used EMR records to quantify it. And we were able to show that this is an extremely leaky system. And so what you have in terms of measurement and decisions in the primary care that actually end up coming out and sending people to both the behavioral health specialist or the psychiatrist, most people don't show. But then there was another problem, which I'll talk about in a second. But before I do that, I'll describe why this model was very helpful. One is that it supported communication between MDs and non-MDs. And so the behavioral health providers were very, very appreciative and felt like they were heard. And what it essentially did is it helped with the scope of work, helping others understand the scope of work of everyone in the team. So for example, we actually interviewed a secretary that was talking to patients, and patients were telling them, oh, I need to see a psychiatrist and I need to go outside and I don't have, access. And essentially that secretary said, oh, but I can book you with I have the schedule for the psychiatrist, so I can book you in for them. Not recognizing that the whole model is about sending patients externally for care, and the psychiatrist is only supposed to be a support work interaction for the behavioral health clinician. And so it completely ruined the model on how it was supposed to work, because someone was siloed in their own work saying, how can I help the patient? And at the end of the day, they didn't, because by the time they went to the psychiatrist, they had to go and find another psychiatrist externally. So this is understanding the scope of work of others can be really, really helpful. And as we had talked about it before, decreasing unwanted and not useful system workarounds, or fixes, as I call them. So now we took a prospective model and we said, now if you wanted to design it, how would you design it? And this is where we're bringing in the model-based systems engineering. And this is where we describe the integrated behavioral health model as something that, if you look at the core functions, engage, identify, assess and triage, diagnose, decide, and deliver, it could be applied to just about any kind of treatment, and not just behavioral health. But here we described it for behavioral health, and we took this model and now we describe it. It's the same four that you see here, and we talk about how people come in, inputs, outputs, where they might not need, where engagement might end, and what information, screening signals, or consenting that moves people through that process. And so if I take each one of these boxes and I zoom in, then you're able to detail very, very specifically what happens. And what you'll find is, even at this level, if you start implementing at different centers, that you'll find different things happening here. And what kind of data is coming out, and how do you coordinate it, and how do you ensure that it can be used across different aspects. And as you can see, things out of even something in the treatment phase will come back up and support the engagement phase. So that interaction is captured and understood relative to the other functions. So if we take just one of these, determine needed behavioral health services, and zoom in, then one of the things that we did for this project is that we explicitly named and stated the key factors for the decision and the recommendation to actually refer to behavioral health or not. This was typically described as, oh, it depends. And generally it depends on the clinician's experience. And so we went after that a little bit, and I said, okay, I'm not asking you what the decision is, I'm asking you what the factors are that lead you to that decision. And I don't need to know how you get to the answer, I just need to know the elements of importance. And so as you talk through it, you could actually come up with something that now you can actually train people and help people come to a better decision, because you've actually named it and written it down. But you can also detail things like, engaging in curbside consult is the red one, and showing activities that require more than one person. Some of these activities are one person needs to perform them. Others, like engagement, is one that requires the behavioral health clinician, the primary care doctor, and the patient to be there at the same time. So at various levels of details, you're able to see who's doing which pieces. We also were able to just describe form. So typically people will say who's involved. And here we were able to include something like the technical resources. So what most people don't incorporate is something like, well, primary care is just exam rooms. But if you're talking about mental health, you don't want to sit in an exam room. You actually want to sit in something more personable, like an office space or something like that. So how do you find that? And that's something that you actually have to find in your space when you're trying to integrate. But there's also the acknowledgement and the understanding and the writing down of who the stakeholders are. If you're referring out, you need to have this list of who you're referring out to and understanding what their limitations are to understand how it affects the system congestion for you. Because if patients can't get care outside, they're just coming right back into the system. And you just went through this whole process to identify that they need to be externally facing, see providers externally facing. But if they can't receive care, they're still coming back into your system. And so they're congesting your system. So we implemented this at Dartmouth Hitchcock. We also had just the high-level model be used by Stanford to actually form teams that were out to actually perform each of those functions. That was their goal, rather than trying to implement the high-level form model. And they found it to be much more successful in terms of being able to track what goes into each piece and how to evolve it through the full process. Oh, one last thing is the automatically calculating measures, the warm handoff. The whole point of behavioral health intervention implementation into primary care is that you take the patient and you say, here's the behavioral health clinician you're going to talk to. Have a warm handoff, and then they're more likely to actually come back for the visit. And so I asked, well, what's your warm handoff rate? And they said, oh, I don't know. We have so many things we're doing. Like, we don't need one more thing to do, please. And I said to them, well, if you designed a process where you had a specific way, if you actually had, and this actually happened where we found in pediatrics, there was only one behavioral health clinician. And every time she ended up seeing a patient as a warm handoff, she put it in as a telephone note. And then every time she saw a patient as the first time, she just put it in as a regular visit. So because of that dictated process, I was able to go in and calculate the warm handoff as 27% without anyone needing to actually note it down as, was this patient a warm handoff or not? So these are the ideas that are really critical in medicine, in that people feel like every single piece of information, I need to put it in to get it out. But that's not the case. If you're designing something with different processes, these measurements should be designed to come out of your system rather than putting a log and focus on your providers to ask them to do it. So this is a different project. This is an end-of-life project where we were trying to understand, how do you improve a system? And before you try to improve a system, you have to understand how it behaves. So in the US, this is a little bit focused on the quality measures focus. So we use claims data, and the current end-of-life measurement approach is one where someone has come up with a certain number of quality measures, and you feed that back to the healthcare system, and the system is somehow supposed to improve itself. And so this is real data for a hospital that essentially has it's 8 numbers that it's provided. And so people say things like, oh, well, if I change one, how does it affect the other? Which one should I change? What if it affects it in the negative way? What are the interactions? What should I actually do? And the information is, there isn't any actionable information. You just provided someone with 8 numbers, and they have no idea how they interconnect. So instead, what we do is we take that same claims data and we create, based off of this same hierarchy of the modeling that we have, we describe different aspects of care so that you actually have a picture over time and you can see the dynamics and the levels of details. This is a very high level: measurement at home, decisions at home, treatment at home, at residential, at outpatient, ER, and inpatient. But if I cared about a palliative care visit within the ED, I can specialize decisions at ER into something like palliative care decisions in ER. And I could specialize them more and just show more details. And so then we aggregate that up to the hospital level. And here's an example of, this is all real data, 4 hospitals. And you can see that you have a hospital that ends up with lots of visits at the very end. And you start referring to hospice a little bit late. And you have another one that is actually much less, and hospice referral, it occurs more and earlier. So this allows you to see the timing and the intensity and when things happen. It also allows you to see how things are happening relative to each other. So is this all happening once the person's in the hospital, or is it happening, you're seeing some people are referred outside? So you get to see how elements actually affect each other. If we take, sorry, it's low, the figures are very heavy. If we take one of those lines, and this is the hospice signal, and I look at it for the 54 hospitals, I've organized them by the quality measure. You can clearly see that these signals are not organized in any kind of real description. So the quality measure that you're capturing at time 0 when the person dies does not capture the dynamics of how many people are in hospice prior to that. And so this is where we have some gaming happening. And so people recognized it and said, oh, well, I don't want to know how many people are in hospice at the day of death. Tell me how many people are in hospice 3 days before death. And then you find, oh, it goes from 10% 3 days, and then it's 20% the day of. So there's people are referring at the very, very end to get their quality measures up. But that referral is horrible to the patients and their experience, because the families are doing this referral and wasting their time instead of spending those last day or two with their family members. So it's actually poor quality care, but it's so that we can improve our quality measures. So those are not in the same axes. But what this does is it allows you to see where the change is happening. And so there isn't this gaming, because it's aggregating a quality measure up. You've disaggregated the information down, and you haven't summed over time. You're actually showing every single day prior to death. Furthermore, you could take that one signal from a hospital, and now you can split it by different patient groups. And you can say, okay, well, for patients that are white versus patients who are non-white, does the signal look the same or different? And then you find that at a different hospital, the opposite is the case. You can't say that non-whites or whites are treated better or worse across the system. There's actually heterogeneity within the hospital. So it tells you that you need the information, the detailed information. And so this same modeling approach, as you delve down, takes you from implementation and quality problems into equity problems, and you're able to understand those better. So let's talk a little bit about the digital transformation aspect. So I was up here a decade ago in the wellness app space, not very interested in that, because I'm interested in improving the lives of people with chronic conditions. And what we've seen, especially through COVID, is that there is, at least in the US, the digital health funding began to mirror the biomedical venture capital. And essentially what that means is that the venture capital is funding these digital health entities and startups within the same siloed aspects. So for cardiology, for this or for that. But we are seeing that the scale and scope of digital health is growing. And as an example, I took one seed fund, Rock Health, and they put out a Rock Weekly, the Pulse of Digital Health. And here's what it looked like for November 1st of this year. You have Health Joy that lands 60 million, Hazel Health at 51.5, etc. So what I did is I went through these different startups, and I looked at their website, and I modeled what it is that they do using our systems model. And if I visualize that for you, it looks a little bit like this. It could be patient-focused, so it could be for patients. It could be for a specific kind of patient. It could be for a specific type of patient, or it could be for a specific disease within a specific aspect, within a specific portion of aspect of a patient. Or it could be system-focused, healthcare system-focused, primary care, orthopedic care, etc. So if you take Health Joy, they are actually providing measurement, decisions, and treatment to the patient population as a whole. So you can kind of map out the scale and scope. Then there's Electronic Caregiver. Nope, it's focused on menopause, measurements, and decisions. Hazel Health is a little bit more for pediatric care, decisions, and treatments. on and on. And so essentially you can reimagine the classic brick and mortar delivery system into a digital healthcare system that addresses the aspects that we talked about, issues of care coordination, integration, and communication. So you could forgo the legacy system and move into, as we discussed before, behavioral health has essentially foregone the legacy system, which was not very detailed, or there wasn't so much of it. But you might want to focus and think about interoperability in silos. So what I just showed before, essentially, these are platforms for the system or for the patient or for certain aspects of the patient. But then how many of these are we going to have? And are we going to have interoperability? What if I'm a menopausal woman with breast cancer? Which app do I use? Can it integrate? Can it not? Etc. So I'll talk a little bit about the story of Ginger.io. And they describe themselves as an on-demand mental health care. And I describe them again because I have no affiliation with the company, but the research that we ran in cooperation with the MIT Media Lab is what spurred much of this work. You'll find our papers on their website. And so they began as a research-focused company where they could track behaviors with mobile apps to detect mental health changes. That's essentially what they could do. Then they recognized that, well, you can have the tools to identify the need for care, but there's no access to it. So you can measure it, but you can't treat it. And so who cares? So then they recognized that, no, actually we have a big problem, and that's the demand for services outpaces the supply for clinicians. So they said, okay, now we're going to evolve to directly employ clinicians in its system of coaching, therapy, and psychiatric services. And they do this using text and video. Then they recognized that who's paying for this, at least in the US, it's an employer model of you get your insurance from your employer. And so they started to look at, how do they sell to employers? They became in-network. And essentially in 2016, they moved from selling to providers to actually becoming a provider. So now they're actually hiring clinicians. So they transformed from a data driver to a solution supplier. Essentially, what they were doing along the way is expanding the scale and scope of the problem that they were after. And in 2021, they actually merged with Headspace. And so I found this quote to be really revealing. Through this merger, we can uniquely tackle the full spectrum of mental health needs, from prevention to clinical care, all from one integrated platform. And so what we're seeing is that mergers and acquisitions are helping these digital companies move into becoming and creating platforms and integrated platforms. There were many, many M&As that happened with Ginger. And then finally Ginger M&A'd with Headspace. And this integration is happening. And so as we think about digital technology and integration, it's one thing that we should have an eye on is, well, where is integration in all of that? So in conclusion, the digital transformation, I believe, is the fastest and most disruptive approach to addressing our current legacy healthcare system. It does require identifying the heart of the problem, or really thinking about what's the real underlying problem. And there is a need for considerations of interoperability and multiple needs of patients. And this structural transformation really needs to combine digital and systems thinking to address the limitations in solving siloed problems, and instead solving more end-to-end solutions. And these solutions would address the siloed methodological approaches and siloed clinical approaches. Thank you.